Time to work on the arms because it's going to be such beneficial work for y'all. So we're coming back to the longitudinal fibers in the body, the north-south fibers. We've been running in different directions here in the trunk, all different directions. The arms, much like the legs. There's one bone, two bones, two bones. The thing about the arms is they're much more movable. So we do have to anchor at times. So there's four sides. What do we have here on the back? Triceps. Feel your triceps? Okay, so you can actually take that in your hand and feel your triceps. How about your biceps? On the front. And did you notice when you felt your biceps, I noticed, at least Brandy did, she rotated her arm laterally to access the biceps, and that's what you're going to do when the person's on the table. You're going to bring the arm into supination to access the biceps. What do we have down here? What's this soft side, the underside of the arm? These are the flexors. And then on the back side, the extensors. So in anatomical position, the flexors go to the medial condyle and the extensors to the lateral condyle. So that's where you'll be taking your stroke. So when you work on the back side of the arm, you'll be coming out to the lateral aspect. That's where the attachments are. Sink your fingers in there towards those extensor attachments. Feel some good places? For those of you who have been doing massage, playing video games, playing guitar, or any other things that you might be doing. Activities. Okay, so four aspects to the arm plus the hand, wrist. What do we have around the wrist? Retinaculum, rubber bands holding down those tendons just like you do down here. And then of course working with the hand, the fingers, both sides, lengthening, spreading throughout the whole arm. So somebody comes to you, oh, my arm's aching, oh, I have numbness and tingling down into my fingers and hand. What are you going to work with? If someone comes to you and they have maybe achiness in the arm, neck, tingling in the hands, fingers, you might work with the neck. Any specific structures of the neck, chest? Which muscles am I thinking of in particular? Pec minor. Pec minor is the one running right over the brachial plexus. So that's what's sourcing the arm. Brachial plexus coming under the clavicle, under the pec minor, and coming out and sourcing the arm. So if there's any abnormal sensation in the hand and fingers, then you want to look to what's sourcing that. So you're not just going to work with the arm, you'll also address pec minor, and then also someone mentioned scalenes as well. So there's three sets of scalenes on each side, and between medius and posterior scalenes, the brachial plexus runs through, innervating the arm as well. So if those muscles are shortened, working really hard, can compress on the nerve, causing pain, numbness, tingling into the hand, wrists, fingers, carpal tunnel syndrome stuff, sensations. Any questions about the arm? Okay. So Megan's going to do the demo, she's going to be the demo. I'm doing the demo, she's being the demo. Would you like to stand and tell us your internal experience? Just feeling from your feet, through your legs, to your pelvis, through your trunk. In particular in your shoulder area, noticing any holding, noticing how closely your arms are to your body, how close your arms are to your body. Proper grammar for the video. And notice what happens when you laugh. And anything else you might be aware of.
I feel like this arm is like up and forward.
And is that the same hand that you were talking about?
Yeah, it is. Because I was like, I'm going to see if it's really what I'm noticing or if I'm noticing my other side. And it is. It's, I feel like it's like this. Well, obviously exaggerated, but
Interesting.
it feels more forward. Like, I feel like this is almost on top of my thigh and this is more on my side. That's the sensation I'm getting. And I just keep wanting to do that. So, but yeah, even now, and I think probably because I just gave a massage, I'm very aware of sensation in here.
So
I did in neck work, and so it's like,
yeah, so you're pulling up with that.
Yeah.
So show me the line of where you feel sensation in your hand.
These two fingers down through my palm, and then and it stops here, like just now, just feeling it. But if I were to engage this finger in particular, like this, I can feel it all the way down. And that was what happened when I heard it. So, and if I pull hard enough, I can feel it. I don't want to do that now.
Please don't.
Yeah,
that's fine. Okay. Anything else?
Shoulders feel tight.
Where? In the front, in the back,
here,
on the
upper
top.
Traps just are like
Holding the world up.
Holding.
Okay. So I imagine you would like me to work with your right side.
Yes.
Okay. So we can divert our attention as Megan gets on the table. She's going to start prone because we're going to start with the triceps. I guess you don't need a pillow under your feet.
I already moved him. Yeah.
Do you prefer that having a pillow?
I only really need it when I'm face down, but this is fine.
Okay.
I'm down now.
I know.
Are you face down now? I either want a pillow or I'll put my ankles up. So. You want it? No, okay. I'll just move my feet.
Okay, so back to lengthening, spreading, differentiating, similar to what you saw and experienced with the thigh and leg. So some of this I'm going to trace because this could be a very long demo if I did all of these strokes. So you can use a variety of tools for lengthening. You can start right on the olecranon process. And notice I'm holding the arm down because if I don't, it goes like that. And also see how it jolts into the shoulder a little? So just that little bit of holding back can really make that distraction go away. Possible distraction. Oh my goodness. I'm going to have to go lighter.
You have to go lighter?
Because otherwise this stroke is going to take a really long time.
Yeah. My body tends to take a long time.
You okay if I go a little later? Okay.
For purposes of education, I guess it's okay.
For purposes of practice, so they get more time to practice. So this idea of holding fascia back can be used in a lot of places in the body. If you go up the back, should you be going up the back during a stroke, it's great to hold tissue down so you don't push everything up. So then we might go back to specific areas with spreading. So one spreading tool is cross fingertips or finger pads. We also have, what are some of the other spreading tools we have? You remember? Open fist, knuckles. So open fist, fanning out. So this would obviously be for larger tricep areas. We also have knuckles. And I think there's one more. Remember what the other one is? Heel of hand. Mm-hmm. Uh-huh. In the same place? Mm-hmm. Well then, I'm not going to be able to do heel of hand very well here, but I'll try. I can do it. Am I doing it? Is it working, Megan? Mm-hmm. Generally, this works better in larger areas, the heel of hand. Okay, so then differentiation, we can encourage movement to help pull us through. So if you would flex and extend your arm at the elbow. And butter knife, that's the BF up there. Or BK. BF. What does BF stand for? Oh, and then BFF, best friends forever. Somebody said to me the other day, I told him you were one of my BFFs. And I was like, what's that?
Obviously, you don't feel the same way.
She's just 20 years younger than me, so I just, it's a whole different. It's a nice thing, right? I'm glad. Okay. So yeah, really feeling. So you'll really feel it pulling away under your hand as she flexes her arm. So see how wide I am? This is basically a differentiation between the biceps and the triceps. And see how I'm lifting up here? If you don't do that, you might end up getting caught in the armpit when you do this.
Are you using the same pressure on both sides, or a little different because it's sensitive on the underside of the
Tell me, Megan.
It feels the same, and it's not sensitive on the other side of my arm. Or me.
mine's taken.
I'm not very big like
That's what somebody else said before clinic.
Yeah, I had clinic yesterday.
Okay, my dear, you can turn over. Oh, you're. That. Okay, now I'm moving over here. Got that? I didn't do that because I never do it that way. I have to change the board.
What? The sheet?
The extensor side of the arm.
Oh, sorry.
Would like a little extra pillow here because sometimes when the person is lying supine,
That's why.
that it might be fine for me to put a lot of pressure here, but there is some space there. So I'm going to go ahead and put a pillow underneath that so that I have that as leverage and I don't have to feel like I'm twonking her arm. That's a new word.
Good one.
So imagine a lot of you are going to like this, working with the extensors, having your extensors practiced on. I'm very aware of this mic today. I'm not usually very aware of it. It's like right here.
Don't touch it because we can hear that.
So obviously if your fingers aren't strong, you could use an open fist with this whole hand. You could certainly come into
I've had some nice elbow work in here before.
Is this doing anything with your shoulder? Is it making your shoulder? Is it jolting up into your shoulder at all?
Mm-hmm.
So, you know, it's kind of an art to be able to hold the hand without gripping it so that you're not jolting up into the shoulder.
Those last like 2 inches were really sensitive. Whoa, hello.
Good morning.
This is the spot in there.
What are you feeling? Like, is it like a burning feeling or?
No, it's like a really high pitch. I mean, like I often feel things.
My elbow's screaming.
Not screaming. It's just it's a different.
Could you please go lighter?
Yeah, it's just a. It feels bright. I don't know.
What are you guys?
Okay. So this is, see, lengthen, spread, differentiate. It produces the same results.
I should do this all the time.
So starting with the hand. Starting with the hand in neutral, which means the thumb is to the ceiling. I'm going to hook my thenar eminence. Do you know what a thenar eminence is? It's that bottom fleshy part of your thumb.
What's it called again?
Thenar eminence. So I'm going to take my thenar eminence and I'm going to hook this spot right here, this extensor region, brachioradialis plus I'm going to go through the extensor tendons. I'm spreading it, so I'm immediately rotating the arm as I'm spreading out. So I am going from medial to lateral.
It's getting more sensitive as she goes.
Just let me know if you would like me to lighten up.
Nope.
Or go slower. Although I feel like I can't really go slower, like I'm going to just slip off almost, like I'm having to hold myself back.
Feels really good. Feels like it might blip. Or it's just a sensation.
We might blip.
Yep. I can totally feel that going up and down.
I'll lighten up as I feel that blip coming.
Usually they don't hurt.
There, you got it. You got it anyway. So a lot of times in that area, so then that would be a great place to differentiate or come in with a more specific lengthening. When you do blip over areas, when they're so taut that it's really hard to get over them and spreading, like in the middle of the back, you know, there's those really ropey areas. So then I'll come in with a butter knife to specifically differentiate, certainly a more specific lengthening on some aspects of the tissue.
Feel it. You're like, oh, yep, there it is.
Anticipation.
I can feel that down in my hand, like in my knuckles.
What exactly did you do to your hand?
I pulled a tendon climbing, but I did it like 3 weeks ago. I was working on a route where the hold is just these 2 fingers, and I was doing it fine and had no problem doing it, but I must have strained something in that process, because then I did an easier route and I was just holding on to a hold like this, and I felt this finger, there was like a pop and it just zinged all the way down and I fell right off the wall and I had to let go immediately on that hand. It sucked.
And you're just now starting to feel it come back?
No, I got some work on it and I had to not do massage for a day, and then I iced it and stuff, but it just hasn't really healed completely. It's still funky.
So also for this position, you may want a pillow for less torquage. That's a word. Proper grammar.
It is.
something here, in here, connected to those fingers?
It's
I
there.
mean, the way you described it, it seemed like
It
the
is.
flexor side.
It's gonna be up here. I can feel it. I can already feel it coming from way down there.
Uh-huh.
And I can feel it in my hands. I haven't been able to like pull down with this finger, even like rolling my window down, like electric window. If I do it with just that finger, I can feel if I did it hard enough, it would tweak out again.
Mm-hmm. So see, I'm heading towards now the medial condyle of the humerus, where the flexors are attaching. So this is another area that can be tight, sensitive, up near the attachments of the flexors.
Yeah, this side feels more fiery. It feels more like hot and congested.
Mm-hmm. Any specific areas you could point to that you'd like me to go back with a little bit of spreading?
It's closer to, like in this area is what it
In
felt
that area? Okay.
Yep. I can feel that down my hand and above. I can feel it like in here and into to your hands.
So are you palpating for a specific thing or just getting in there?
I am going by what she said. I'm staying with the flexor tendons, so they come up again to the medial condyle of the humerus. So I'm addressing the areas that she talked about. Does that answer your question? What did you mean by that?
I mean, I guess I was wondering, is there a specific muscle you were targeting? Or anything like that?
I'm targeting the flexor muscle, the general flexors running in this area because of what she talked about in her fingers. And I feel like I could do more in there. And I'm going to continue on. Should I do that? Okay, so we have the wrist. So there's different ways you can work with the retinaculum. There's different ways that you can call for motion. I'm going to do a passive anchor call for motion where this is doing the hand movement. This one hand's doing the hand movement. This other hand, I'm going to use my thumbs. I generally save my thumbs for hands and feet. And I start on the hand, and as I flex the hand, I go over the retinaculum. You see that? So you can do 360 degrees. 360. All the way around. So trying not to let your thumb get far out from your hand when you're using it, keeping it all straight. You can even go on the lateral aspects a little bit. There's a little bit of lateral flexion. So you're shortening the angle, hooking in on the hand, and then opening up the angle, coming across.
Sounded more sensitive on that side.
Mm-hmm. In there.
That was gritty.
So you can also do it on the underside. You can do it right across this area. You could start on the heel of the hand or a little after.
Yeah, no, it popped up and won't screw back on. So I was gonna wait till you fix it.
You're strong.
I mean, if you want me to lift everybody up and put it back on.
No, I'm not talking about that pulled off. I'm just kidding. Anyway, okay, so hand. So you did hand in reflexology, did you? Spend any time with the hand?
Yeah.
Okay, so here what I'm going to try to show you what I'm doing underneath. I'm going to sink in and I'm going to come out across, pulling my hands away from each other. So this takes a little sinking in, a little strength, a little different than the body weight aspect that we usually talk about. But really getting into that heel of hand, feels so good. See, I couldn't start on her heel of hand because there's just way too much going
stuff in there.
on.
How do you find yourself compensating on the other side, or the one that you injured, Megan?
I haven't noticed. I tend to use my left side more anyway.
So this whole part in the webbing of the thumb, and these things you can feel on yourself. Feel that webbing of your thumb. This is a great way to learn more about massage, is to palpate these areas on yourself, do self-massage. So getting the webbing of the thumb in there along the metatarsal of the index finger and the thumb. Yeah, there's a lot. There's just so much you can do in the hand, and you could spend a whole session just with the hands and the arms. You guys getting bored?
I started a chain reaction. I didn't mean to.
Just happened.
It did. It just happened.
Okay, so I'll try to like quickly move through these things so you all can, not too quickly, so you all can have more time to practice. So you can do cross thumbs. Cross thumbs is not pulling your thumbs away, it's crossing your thumbs, bringing them into an X. Oh yes, client. Spreading, yep. So you can lengthen and spread both sides, the palmar side of the hand, the dorsal side of the hand. You can do all that on the back of the hand. You can lengthen, you can spread. Even with those metatarsals that you wouldn't think you'd want to go over, there can be sensitivity and feel good if you stay with the superficial fascia. You can obviously do the fingers, spending time with each finger, being present all the way through. I mean, you could work between the knuckles, you could work on the other side in between the metatarsals. There's a lot. Lots. Okay, so you've got the hand, the wrist, extensors, spreading. You could certainly spread in other parts of the extensors. Differentiation, lengthening, spreading. Yeah? Pretty straightforward? Okay. Yeah, so the biceps you want, as I was saying, you want to have the forearm supinated. And you can do it with hands, you can do it with open fist. Megan showed some fancy thing with the heel of hand this morning.
Did I?
I know, they were all doing like this. I was like, that looks so fancy.
That's how I did.
So you could do it with your heel of hand sideways like that.
Yeah.
As it says up on the board, you're gonna be like, what is all this stuff on the
Well,
board?
it's like I said you can use whatever tool you would like. I am going to use this tool.
Okay, so notice her arm's like this lever.
Or lever.
You guys are too giggly. You're not allowed to partner together.
Certainly not allowed to be the demo together.
Quiet atmosphere, right? Quiet
Right, we're quiet and serious here.
Volume. Volume. There's too much side chatter in here. Don't agree.
Okay, so did you get that? You got the whole lengthening of the biceps using the arm as a lever. Okay, so working with the biceps, actually, if you were with finger pad mode, you could just come right up to that coracoid process. And you could sink in, you could change your direction, and you could begin to address pec minor. Remember this one?
Yeah.
Yeah, this one tends to get forgotten.
I've got a lot of these puts
So you're going inferior, a little medial, but not too medial, not like you're heading towards the sternum. And letting the movement of the arm propel you through.
It's getting thicker.
And then sometimes you'll feel little rounded areas or bulbous, I wouldn't call them bulbous areas on the rib cage. And that's where it's attaching. To address scalenes was the way that we address scalenes in class. We came in this area and invited rotation laterally, so that's spreading through the scalenes. And then we also did that modified open fist through scalenes. Okay, so there's one more stroke. The stroke. So, okay, you'll probably have time to address one arm, but if you were just going to do one thing on an arm, you could go to the other arm and just do this stroke. So these are molding strokes. We'll introduce them throughout the body next week. And the idea generally is up the inside and down the outside because of the forward flexion, the medial rotation that happens in the shoulder girdle, up and out. Up the inside, down the outside, rather. Okay, so this one you're going to start with the arm in neutral, thumb to the ceiling, and I do use my leg for leverage. I'm in a lunge position, and I sink in with my finger pads. So this hand's going to start up here with the open fist on the outside. Y'all getting this?
Yeah.
See that? Finger pads, and what's going to happen is this is going to come into the whole hand, and this one's going to pronate the forearm. You like that? They like that. Okay, it is a little awkward for some in the beginning, and you're not here, you're here.
You have a problem with one hand wanting to go faster than the other, or is it usually balanced?
That's fine if it does. It's okay. That just shows that you're really listening to tissue.
I knew somebody was going to say it. There's always somebody that says it.
What is that?
Okay, so when I do pass in the night, I do come up a little bit. I can come up a little bit, and then I can come more into my body weight doing the stroke rather than muscling it. So that can be one arm. If you were just going to do one arm stroke, that could be your only stroke. Or it could be a finishing stroke. After you've lengthened, spread, and differentiated, when they're,
Hyperextend the elbow or something like that. See if that's what you can do in the back.
you mean that particular stroke?
Yeah.
I don't think it wouldn't pronate the same. Wouldn't have the same because you're like this, so it wouldn't move. Just stay there.
Can you do it then? Are you saying can you do it that way? Are you saying it can't?
No, it's not with the same intention, not with doing, because you really have the full movement of the arm here. When the person's prone, it's just pretty much that, because you don't have this way, because their body's in the way. Okay, so what do you notice from your right to your left?
Because the arm feels bigger. Like, if I just to close my eyes, it feels like this arm is so much bigger than this one.
Mm-hmm.
And yeah, I mean, it just feels like there's a lot of circular movement going on in it.
And I know we didn't touch into the pec minor we did. How was that area?
Great.
Yeah.
And especially when you got, I guess, closer to the attachments, it felt like there were more things going up in there.
Mm-hmm.
Yeah, right in there.
So given Megan's standing awareness and the intake that I had with her, my sense was to go for those areas first, because that can be the educational piece. Oh, wow, it already feels better. And then we can work with the areas that have been stressed by the sensation happening.
Yeah, when I close my fist now, I don't feel that tightness in my
Really?
Yep.
Cool.
I was feeling it every time, like it would be like, kind of tight. And it feels a lot easier to
Great.
do that.
Cool. Thank you, my dear.
Thank you.
Okay, any questions? So you'll have about 40 minutes each way if you're real efficient with your... Okay, so we're going to start off with the bony landmarks of the low leg. What's this right here on top? Patella, yes. And this is a floating bone that's surrounded mainly by tendinous tissue. There's a bursa that lives below. And then, so the bone above is the femur bone. And here, touching the anterior surface of the leg, following that bony shaft, this is the tibia. I was into muscles. So feeling the tibia and the tibial tuberosity, and then just moving laterally. Do you feel a little head of a different bone? Yeah. What's that called? Right, the fibula. And then just following the tibia down, you can try to feel if you can palpate the fibula below all the mass of muscle, and just following it to the ankle bone and noticing how the tibia is part of the medial malleolus, and then the fibula is part of the lateral malleolus. And then we go into the bones of the foot. What is this big bone here? Right, the calcaneus. So that's going to be an important landmark for today's session. And we've done this in reflexology, so we won't get so specific, but you can feel on the medial side, just a little bit anterior to the medial malleolus, is the navicular bone, and you can kind of invert and evert the foot and feel that popping up. The talus is between the calcaneus and between the tibia and fibula. So this bone's kind of, it's a little bit harder to palpate. You can try just with a little bit of dorsiflexion and eversion and see if that bone will pop up above the navicular and below the medial malleolus. Don't worry about it if you can't palpate it. It's in there. It's surrounded by a lot of ligamentous tissue as well. There's no actual muscle that attaches to the talus. So just moving a little bit more distal, we come into more of the talus or the tarsal bones,
and there's the 3 cuneiform bones, which are on the medial side of the foot, and then we have the cuboid bone, which if you find the 5th metatarsal where it flares out at the, does anybody know what that flaring part is called? The styloid process, yeah. And if you go just into that little notch, there's the cuboid bone. So then we have all the 5 metatarsal bones, and you can palpate the heads of the metatarsals just by bringing your toes down and feeling the heads. And then what are these called? Not only toes, but phalanges, yeah. So there's also the proximal phalange, middle phalange, and distal phalange on the 4 most lateral toes. So those are the bones. We're going to start with the posterior part of the leg. So the 2 muscles, or the 2 muscles in the posterior that are most palpable, the most superficial one that lives on top and has 2 heads, does anyone know what that's called? Yes, gastrocnemius. And gastrocnemius, it crosses 2 joints. It crosses the knee joint and attaches onto the condyles of the femur in the posterior part. And so that helps us with flexion of the knee. The gastroc also feeds down into this dense tendon, sometimes called the calcaneal tendon, but also called the Achilles tendon. And then it anchors right into the calcaneus itself. So that also will help us with plantar flexion. There's a muscle that lives below gastrocnemius, and it's kind of looks like a fish, and its name comes from that. Does anyone know what it's called? Soleus, yep. And soleus, so it's kind of fish-shaped, and it's living deep to gastroc, and it's attached to the posterior part of the tibia and fibula, and then again feeding into that dense fascial band, that dense calcaneal tendon. So if you go ahead and plantar flex, you can palpate the gastroc tendon. So please plantar flex and feel the 2 heads of the gastroc popping up, and then go ahead and again plantar flex and feel soleus popping up, and then see if you can feel that calcaneal tendon, feeling the difference from muscle to more tendinous tissue. Is everybody feeling that? Yeah. Good. So the soleus only crosses 1 joint, so it mainly helps with plantar flexion. We have a lot of muscles on the bottom of the foot. So these muscles that live within the foot and affect what's happening in the foot are called the intrinsic muscles of the foot. And then we have these muscles that are above the foot but still attaching onto the foot and affecting the foot. So these are called extrinsic muscles and then intrinsic muscles. So living within the foot, extrinsic being external to the foot. We're not going to go into the muscles of the foot themselves, but there is a dense band of fascia on the bottom of the foot. Does anyone know what that's called? Yeah, the plantar fascia, or plantar aponeurosis. And sometimes there's a condition called plantar fasciitis, and that's just mainly inflammation of this fascia. And when it gets inflamed, sometimes it's due to a lot of tension being held above in these muscles of the soleus and the gastroc. So if they're feeling pain here, it's going to be great to work in here and bring some release to this fascia so it can not play such a role in pulling on the fascia on the bottom of the foot. So if you move anterior, this medial border of the tibia, we're not going to really work with today, but you can see the gastroc, maybe on Megan a little bit more, popping up, and then the soleus. So these muscles kind of show themselves in the anterior region of the body. What we will work more with today will be this lateral compartment of the leg, and finding again the shaft of the tibia, and then just sinking laterally. And if you go ahead and dorsiflex your foot, you'll feel this muscle popping up. Does anyone know what that's called? Tibialis anterior, yeah. So this is attaching along the tibia, and there's an interosseous membrane between the tibia and fibula. That just means it's in between two bones, and it's a fascial membrane. So the tibialis anterior is attaching to that membrane and also to the tibia. And then it's a wrapping around the front part of the foot. So if you dorsiflex and evert your foot a little bit, you'll see the tibial and the tibialis anterior tendon popping up, and then it's attaching to the bottom, the base of the first metatarsal head and the medial cuneiform. So that gives us that ability to dorsiflex and also invert the foot. I get my invert everts a little bit confused, sorry. So yeah, invert. Bringing in towards the midline. Yeah. Okay, so that's the tibialis anterior tendon. And if you go ahead and evert the foot now and just look around the lateral malleoli, you'll see this other tendon popping up. And does anyone know what that tendon belongs to? Peroneus longus, yes, yep. Sometimes I think it's now called fibularis. So it does have two names. In the past, it was peroneus longus. Peroneus longus is attaching along the proximal portion of the fibula, or of the fibula. So it's attaching onto the fibula and also part of that interosseous membrane and going down around the lateral portion of the medial, of the lateral malleolus, and then where that notch is, where the styloid process is, it comes around, wraps around onto the bottom of the foot, and it attaches right where tibialis anterior attaches on the base of the first metatarsal and the medial cuneiform. So sometimes these muscles are called the stirrup muscles. They sort of make a stirrup around the foot, and they're attaching in the same place, and they're living right next to each other, but they're having very different actions. So again, tibialis anterior does the dorsiflexion and inversion, peroneus longus, sorry. Plantaris is somewhere else. Peroneus longus does the plantar flexion, and it can also do eversion. So they can do them independently, the movements, or they can do a kind of a combination, so we get that circumduction. But you know, what I want you to really get is that these muscles are living close to one another, doing different things. So we're going to do some differentiation today to give them some space so they can move once again more freely, more efficiently, working better. So living deep and kind of in between tibialis anterior and peroneus longus is another muscle called extensor digitorum. Extensor digitorum is attaching to the fibula and that interosseous membrane, and then it's feeding down onto the top of the foot and onto the proximal and distal second through fifth phalanges. So that helps us extends the toes, and it also helps with dorsiflexion and a little bit of eversion. So you can, it's hard to palpate the muscle itself, but if you work on just kind of going back and forth from inversion and eversion or plantar flexion and dorsiflexion, you might find a little groove between peroneus and tibialis anterior, and it's living deep underneath that groove. The most palpable part is, you can see it really beautifully on Megan, is the tendons that feed into the foot that help extend the toes. There's also another extensor called extensor hallucis longus, and that helps extend our big toe. And that is really hard to palpate. It's living deep below extensor digitorum and tibialis anterior. Again, it's helping to dorsiflex the foot, and extensor hallucis longus can also assist with a little bit of inversion. So these muscles, again, working in relationship really close to one another, doing different actions. There's a few other muscles, of course, in the back. In the posterior part of the leg, there's tibialis posterior that lives deep to soleus and attaches right onto the like the middle arch of the foot. So we may not be specifically addressing tibialis posterior, but it's, the work we do today will have an effect. And again, there's some flexor hallucis longus and flexor extensor digitorum, which will also help flexor toes, but we're going to worry about specifically touching those today. So what's holding this all down, so we have these gorgeous, lovely, shapely ankles, are these little fascial bands called, does anybody know? Retinaculum, yeah. So we have, on the front, we have a retinaculum that's above the malleoli, and that helps hold down our extensors. And then there's another one that comes from the medial malleoli and wraps across and kind of makes a Y shape. And that's below the malleoli, and that's, again, helping to hold down our extensors. So they keep the extensors kind of organized so they don't get all bundled up and gush out so we can wear, cute shoes, I guess. But there's a couple other retinaculums that wrap around the back of the foot. There's one that actually is called the peroneal retinaculum, and that attaches to the lateral malleoli and down to the calcaneus, and that holds down the peroneals. There's not only peroneus longus, but there's also peroneus brevis. And brevis is attaching to the fibula, and then it attaches just to that styloid process of the fifth metatarsal. But it will help with everting the foot and a little bit of dorsiflexion, or actually plantar flexion. And then there's another retinaculum here that helps hold down, I think it's the flexors of the foot. So there's a lot going on in the low leg, kind of like the arms. And any questions on the muscles, the bones, the actions? Could you feel, just from standing today, how if the weight is a little bit shifted, how it could affect some of these leg muscles? Yeah? Yeah. Okay, so we already got our demo. Anything else you'd like to add, Megan?
I think like the biggest thing with feet, in my experience with my clients, is that a lot of people don't realize that all these muscles up here come and attach into the feet. And so they'll come in and really want footwork because they're having pain, and a lot of times it's pain right in one of the attachments. And just taking that time to, bring awareness to the fact that, oh, okay, well, is it all right if I work up here in your low leg, in your tib anterior? And then you can really show them. You can actually have them lift their foot towards them, and they can see the tendon right there. And then they actually have this whole new awareness of how their body functions and works. And it's like, really? I can't tell you how many people are like, I had no idea that all these muscles came down into my feet. I thought it was two separate things. So that's a really nice piece. And, it's just such a huge part of our foundation and how we move in the world. Can you stand up for a second? Just the idea that how our feet move affects our whole body. So I'm just going to lift up your big toe, and I want you to watch the rest of your body. That's just one toe, man. So like our foundation, our feet and our lower legs are such a huge, huge way of how we move in this world. And someone has a limp, someone stubs their toe, or does something funky to their foot, and it's going to throw off their whole body. And so just being able to bring that into our clients is huge, I think.
I had a pastor down in Key West when he had an ingrown toenail, and it hurt to be so bad where it went into the bone that they said they amputated it. And when they amputated his big toe, because they said it was so bad, there was no use saving it. He had just the oddest walk. He had to always have a cane with him. He couldn't walk in, he couldn't run like he used to run like every morning. He said, but you can't run.
I was in this training, and this woman was talking about how a friend of hers had worn high heels from such a young age up until like probably middle 30s, and her Achilles had shortened so much that it was fusing like a bone. So it actually was painful for her to go flat-footed. Yeah. So that's just shortening the whole, you know, as Megan showed with Lauren, how it can shift the whole body posture. Imagine somebody's whole back line is getting that compression, shortening the Achilles, shortening the low back, and how that can just bring the whole front line long. So it's this, what we do to our foundation is going to have an effect. And so standing awareness today is going to be really important. And I would encourage you, if you have an office, to get a muscle chart so you can show your clients what areas you're working with, how they have these relationships. So, anything else? No? Okay, we'll grab a new partner, and Amy, set up in the center. We'll begin.
So what are you noticing just right now in standing? What is intense?
My calves.
Your calves.
Really tight. They actually feel like they're like locked up.
On both sides, they feel that way?
Yeah, both sides. So I think it has to do with the trapezing. I think it was definitely the trapezing.
Okay.
That did it.
And so when you're standing, what is it that feels locked exactly? Can you tune into what is happening just in that spot in your body?
The hell did you do to me?
Is that what your calves are saying?
Yes. Yeah, that definitely was. Yeah, it feels really tight.
Okay.
It feels like it's like it wants to, like I want to bend my knees.
Okay.
It feels like
like this would be more comfortable to just stand like that.
Yeah.
So is it feeling tight behind your knees, or is it feeling tight through the whole backside?
Mostly, I think, just below and behind my knees, but it kind of goes along the whole stretch.
Okay.
But it definitely feels, it is kind of the whole stretch. Mostly like right in the middle, like I think.
Okay.
Right in there.
And are both sides equally
Janked up, yeah.
Okay.
Yeah, I think they are. I don't know, I haven't looked at my legs, I can't see with these things on. I might have bruises
Okay.
back there. Like I noticed that this morning, it feels like where I was hooking my legs on.
Oh, okay, onto the bar.
Onto the bar. I think that's what it was.
Okay.
The swinging was okay. I feel a little sore here. But then when
just the
to get
pressure,
the legs up and hook and then hold them in free swinging.
Okay.
From my knees.
All right. So I'll check in with, and when we get in there, and see if it's tender to touch or not. Okay. So just take a minute if you can, and to just feel how your feet are on the floor, and just give yourself kind of an overall check-in in terms of what you're noticing in this moment, and seeing if your attention is being drawn just to that one area, and if not, what else may be coming into your awareness as you stand here.
I noticed, maybe not so much right now because I feel like I'm trying to correct it, but I did notice this morning when I first stood, I definitely had a really pronounced anterior tilt to my pelvis, and I'm trying to
bring it
keep
back
it in check. Yeah, but that was definitely one thing. My quads feel mostly on the side, feel a little tight.
Okay.
I guess I feel a little
soreness
in here, yeah.
Little lats action.
Yeah. But I actually feel good considering I've been sleeping on
the ground. Nice. Cool. So, in general, usually like when someone has their knees locked, for whether they're sore or whatever, it's usually going to put them into an anterior tilt almost automatically. And you guys can try that when you stand up. I know we talked about it when we went through some of the pelvis stuff. If you just have your knees bent and then lock them, it puts you into an automatic anterior tilt, which also activates your quads. So now your quads are going to have to hold too. So often I would educate my client in that as well. Like, okay, so I'm hearing that you feel anteriorly tilted, and my imagination is that's because your knees have been locked for the last day and a half, you know, and having them try that. Because if it's not something that's really familiar, I would be like, okay, so it may be because of this. And if that doesn't feel true, then that's okay too. So, cool. So, I'm imagining you'd like to start on your calves. Yeah. Is there one side in particular that you'd like me to start with first?
No, they both. Is it one or the other?
Well, for the demo, it will be.
Let's go for right.
Right. Yeah. Okay. Cool. So if we could let Amy get on the table in pseudo privacy. Are you ready for that? Hold on. Stop. Is it okay if I tuck the sheet in, or are you a non-tucker? Okay. Okay. Some people really don't like the tuck, and other people love it. I'm a lover of the tuck. Mara is not. Mara and I do things very differently, and yet successfully the same. Yeah. Are we going? Yes. Okay. I keep forgetting to look at you for the.
I forgot that.
And then I was like, I'm already starting. So you do have a little bit of bruising here. Yeah. Is this sensitive when I actually put pressure?
Yes.
Okay. So I'm going to be careful of those.
But it feels really. I don't know how much pressure I'll be able to take.
Okay. They're really sore.
So I don't know if it's the muscle that feels sore or the bruise.
Okay. So, lengthening. You can actually start and do the whole leg. I'm actually going to do that.
Okay.
And again, you're going to just come right under ischial tube. And this is, just let me know about pressure, Amy.
Use a little more here.
Okay. How's that? So just let me know if I need to shift as we get closer. A lot of times if, even though she was speaking specifically to her calves, because she also mentioned her anteriorly tilted pelvis too, if I hadn't known it was because her knees were locked and it was just that her calves were tender, I would address her hamstrings specifically to bring more awareness to her hamstrings and less into her quads, so that I could be like, hey guys, you know, let's work a little bit this way too. So as I come around the knee, as I come in, I want to address these attachments from the gastroc and soleus. So you can bring this lengthening stroke all the way down. And depending on your client, you can still use 2 hands. How's that on those bruises, okay?
Yeah, that's fine.
And it has the pressure in here. You can continue to use 2 hands, or you can shift into one, which most of you probably will have to once you get towards the Achilles. And that happens just like this. And just take one hand off. And you can use it to brace the other, or I tend to try and make contact somewhere else. And you can keep your fingers going towards, or I like to shift my hand so that now my fingers of my open fist are pointing towards me. And this way I can go up the Achilles, which I just had to shift my posture. If you guys notice, I really had to come forward to come up the Achilles because I'm going uphill. And now once I get over, I can stand up. My wrist is straight. And I can come down the feet. So that was one lengthening stroke covering the entire back side of the leg. How's that feeling there? Feels hot in this space or somewhere else? So since now I'm going to be addressing her calves, I'm going to pull that back down. And so as Jen mentioned, our gastrocs cover 2 joints because they cross over the knee this way. So when I do a stroke, I'm going to make sure that I include the attachments. So even if you were to just lengthen, and you can lengthen going this way if you'd like, you can come in and lengthen like this for the purposes of keeping that down the back. I lengthen this way. With spreading, you can come in and you can use your, I'm going to use my thumbs. You can come right into the, what is this called? Achilles tendon, and I'm also spreading through that big band that holds the broccoli together, retinaculum. Okay. So I'll, still too much? No. Okay. Yep, I'm taking my thumbs and I'm going like this. So like this. I'm just, yeah, I'm just kind of spreading. You can do it. I find that there's not as much room to do fingers because, and with my thumb, it's a broader tool. You can spread. We don't want to spread this way. So we don't want to spread the calves away from each other. The gastrocs, because the gastroc comes up in 2 pieces like this. And we don't want to divide this line here. We want to keep it wanting to move in the same direction. I will spread down here, right where gastrocs and soleus meet, and Achilles combine. And I'll usually just brace my hand underneath the heel, or underneath the ankle, just a little bit. And I'm just going to come out just like we do with the legs, with the heel of hand. And Amy, just let me know, how's that pressure? So I'm just going to come out laterally. And if you want, you can also spread to the other side. Noticing what may feel different or the same. How is that?
But intense. The part that was actually going in both directions.
Mm-hmm.
Like I could feel it again in my toe, but in a different, kind of a different stretch. It's actually like this whole stretch all the way down to my big toe, and then also up into my knee.
You felt it in your knee here or in the front?
More in the front.
So differentiating, so what we're going to do is we're going to actually differentiate between gastrocs and soleus. So most of the time, when someone points their toe, you can kind of see gastrocs and soleus separate a little bit. And we're going to use a pillow because I'm going to ask her to use her own movement. So I'm just going to put this right underneath your ankle. And sometimes you may have to lose the cocoa butter. Sometimes you may have to move the pillow underneath just so she has enough room. So what I'm going to ask you to do, Amy, is to plantar flex and dorsiflex. Now, if she were my client, I would say point your toes and bring your toes towards your nose. So lift your toes up and point your toes down. So does that feel comfortable, like you have enough room to do that? Mm-hmm. Okay. So, and you can stop for just a moment. What I'm going to do is I'm going to start this is an easy muscle to differentiate because you can start right at the Achilles tendon and you can, oh, there it is, it's right there. And what I'm going to do is I'm going to actually come all the way up gastrocs, in between gastrocs and soleus, like this, and into the attachments while she does that movement. And so she's really going to be controlling a lot of the pace and the pressure because as she dorsiflex and plantar flex, those muscles are going to be coming into action. So I'll actually be able to feel, and you'll be able to feel almost in a way where the muscle's kind of pushing you out and letting you come in. Okay, so Amy, whenever you're ready, you can start that movement and you can go at your pace. And I'm primarily just using my first two fingers. And just let me know about pressure as we continue. I've got I have all of my weight into the table with both legs. This is a get comfy stroke. And see as she's doing it, how we can really see. Now that line right there is actually the fibularis longus separating. I'm actually going to come up a little higher. You can see it on the muscle man right where gastrocs and soleus, it's right on top. There you go. Now you can really see it, the difference as I'm coming up. What are you noticing, Amy? So I'm aware that my medial hand is moving a lot faster than my lateral hand. That's common. I would imagine it's because there's more stuff going on laterally. And I'm just let it hang in that tissue. How's that pressure? Is it so comfortable?
Good, yeah.
Did you feel that little roll?
That feels like a really congested space.
Yeah. So I will probably come back to that area once I finish this stroke. Again, and I'm just going to kind of shift my body weight and move with the stroke. And I'm shifting my body weight. I just take my back leg and I spin on the ball of my heel to twist my hip forward and then come back. It's like a little dance move. And then I scoot my front leg forward. So I'm going to come right in to the attachments over past the knees. questions on that stroke? No? Awesome. So I would come back and probably just differentiate this specific place. And Amy, you can either do the movement or you can leave your foot static, however, whatever you feel is most effective for you. How's that pressure? A little too much? How's that?
It's the kind of thing that, like, I feel like, yes, I should keep it, but then I'm like,
Yeah. If you ever feel like you have to hold your breath, then it's too much pressure.
how about the, like, when we talked about stretching, it really sounded good to me, the comfortable stretch is when your other muscles don't contract.
Yeah, you don't ever want to be contracting when you're being stretched or where you're being massaged.
Right, so that's what it rings true for massage, and that's my first thing. It's like it feels good, but I do feel my other muscles, not this, but feel my other muscles contract again.
I generally, especially when I work with someone that's never received massage before, that's the first thing I'll tell them, like in terms of pressure. I'll say if you ever feels like you're holding your breath, or if you feel like you have to start contracting around what I'm doing, then it's too much pressure. Even if it feels good, it's too much pressure. There's a lot of work that you can do in the foot in this way, and you can come down and do all kinds of lengthening. I actually prefer to work in the foot in this position. I don't have to get down like this to really do it. I can use my thumbs again to do some spreading through the feet.
And there you're bringing your thumbs together again?
Just bringing them like over and under each other. Which I'm pretty sure you guys did this in reflex. It's a great place to come in and work the retinaculum. Just in between. We'll do a little bit more retinaculum on the front because we can encourage. And I'm just using my finger pads. Any questions on calves and Achilles? Nope. Okay. I'm going to have you flip over. Yeah, well, of course. That's okay. That's why we are here.
Megan, I do have one.
Yes.
If a client presents with plantar fasciitis,
Plantar
would you
fasciitis.
change any of your techniques that you just used? Would you focus your same attention on the muscles in the leg? Because that seems to be the...
We'll be doing a lot of low leg work with someone with plantar fasciitis for sure. Yep. It's fairly common. I've had quite a few clients that have had it.
I feel so much better now.
So just taking your time to flip. Bing. And again, being aware that I flipped to the other side of the table, as now her right leg is on this side. Constant reminder. Scoot my pillow. And is it okay if I just move your leg closer to me? Often I'll bring my client's leg just closer to where I am. And again, I don't ever really undrape my client except for where I'm going to be working, even if it's the legs. There's no reason for me to have her whole leg out and about, especially when it's a cold day. So I'm aware that you have some bruises here as well.
Oh.
Is this
I wasn't aware.
is this sensitive to have contact?
No.
Okay.
No, not at all.
And that's how I address bruises. I touch it and say, how does this feel? Because if it's really sensitive, I'm not going to go over it. And if they don't even know it's there, then most likely I can contact it, no problem. My experience in general is that most people have no idea they have their bruises that they do. Really? I have that? And I want to bring their attention that they have bruises because I don't want them going home and thinking that I did them. That's huge, especially if you do deep tissue work or you work with sports stuff. I want my clients to know, hey, this was here before I got here. I didn't do that, because I've been accused of that, and I don't want to, so I bring awareness to it. So to lengthen, I'm going to go up. So I will ask my client, I'm going to anchor your foot here, and I'm just going to turn it inward. Is that comfortable? Mm-hmm. Okay. For people who have a lot of ankle stuff, this could be really uncomfortable. It could be the last thing they want you to do with your body. So I check in. You can use your finger pads. And the reason I want to turn her in is because if she's up, or a lot of people tend to fall out like this, her tibia anterior is the bone, the tibialis is right on top here. But the muscle is kind of lateral. And so if I turn her in just a little bit, then she'll be right on top, which is easier body mechanic wise. And if they had ankle stuff, then I would just kind of come out more like this. But she doesn't, so I'm going to just put her in. And again, just let me know about pressure. So someone who may have shin splints, this is a muscle you would want to be working with. This and tib post, which I don't think we'll get into until sports, maybe NMT. You can use finger pads, or you can come down into your whole hand once you get high enough, or wherever you feel like that's comfortable for you.
Are you just working the bruise, or are you?
I'm on the muscle. I'm on tib anterior. Tib anterior is a very strong muscle. It's very palpable too. It pops right up.
Putting pressure with all three fingers?
Yes.
Can I ask you, I'm still struggling with this fingers soft thing. Are your fingers soft?
If you were to come touch my hands, I would imagine that I could show you the difference if I were to flex my fingers. Yeah, I mean, like, so forgive me, if I were to actually tighten my hands, it would look like that. And it would feel different.
Wow, yeah.
It doesn't feel good. And I just felt that in my elbow. So my hand is actually quite relaxed. Even though my fingers are making contact, there's pressure of my body behind that. But I'm not going like this. I'm not tightening. There's no board in here at all. Because if I did that, I wouldn't have been able to do a massage for 10 hours every day all weekend, or whatever we did. So lengthening up tib anterior. To spread it, you can use your heel of hand. And again, you just want to be really conscious that you're not on tibialis, because the bone is very prominent. And you just want to make sure you're not on the bone, that you're just lateral to it, right in the muscle tissue. And now if someone does have shin splints, you're not going to do this spreading stroke. Does anyone know what anatomically like shin splints actually are, what's happening in the body? So, So what's happening is that the tib anterior is usually being used so much that it's actually pulling itself off the bone. So, and it pulls itself in this direction. And so you don't want to spread someone with shin splints and encourage this movement. A lot of times it happens, people who wear cleats and go back and forth between a cleated area and like regular shoes. So soccer, baseball, softball. Basketball players get it a lot, but it's more out of repetition. So I would still work in here, but actually do a lot more work in this side, because you can contact tib post just a little bit on this side and from the other side, but that's another thing. You can also use your, I'm going to show thumbs again. And you guys, sorry, you guys may want to come on this side so you can see it. And I'll show you in the air. I find this, for me, to be the most functional tib anterior spreading tool. And it's, so my thumbs are going to be actually towards me. So my thumbs are going to kind of look like this, and they're going to come down. So my thumbs are facing me, and it's actually a lot like up and over your client and coming like this, except I'm just using my thumbs. And they're very supported. My whole hand is under them. My fingers are under them. And I'm actually going to come up and over. I'm going to start off with my hands like this. No, not. And I'm just going to come down, and I'm going to use my legs. I'm just going to come down, tib. How's that? And you can come straight through tib anterior. You can angle. You can even angle and kind of come at a diagonal through tib anterior. You can even go into or fibularis if you wanted. How's that? So okay.
So you're on either side.
My thumbs are still right next to each other.
Oh, okay. But your fingers are just like
my fingers aren't doing anything but getting out of the way of tibialis. I don't, this is a fairly sensitive bone. I don't know if anyone's ever gotten kicked here or hit with a softball or anything like that, but it swells like that. It's right on the surface. So yeah, my thumbs are just like this, and I'm just kind of going down. It does take some strength, so please be careful with yourselves. You can do it anywhere. I was working in this area specifically because that's where she was feeling stuff on the other side. And you can really sink into this. I mean, it's a strong muscle. How's that pressure? If it's comfortable for your client, you can really sink into it. No movement. I'm just squatting. My leg is just kind of, I'm just kind of spreading.
Your thumbs are moving.
My thumbs are just going down like this. But I'm just, if I didn't have hands, the stroke would just look like this. I'm just doing this. And my arms just happen to be in that spot for her. So as I squat, and I'm applying pressure, but I'm really just kind of squatting and leaning into it.
So would you ever find with connective tissue you never would follow it? Because it seems almost when you get to the side like it would feel good to like follow down.
You can, in general, we encourage the up the body and down the back. And that in connective tissue to just follow the pattern. But you can go in either direction. To me, it's really I'll just ask my client what feels more effective. Like, does this feel better to go this way or this way? And if it doesn't matter, then I'm going to try and follow the pattern of and down. Yep. So we're going to do another differentiation where we're going to come right in between tib, anterior, and fibularis. And Amy, if you could just bring your foot out this way So just, yeah. So instead, I wouldn't say evert the foot. And, you know, depending, some of the athletes know all that by now, but, and you can see really nicely, on most people, you can really see the difference. And there's your line right there. You just follow right up that line. And if you're not sure where it is, then you're just going to start just posterior of the malleolus and superior. So find the ankle or malleolus, and you're going to go just above it and behind it. So superior and inferior, and that's where your line's going to start. But I have very few people where you cannot see that line because everyone stands up. So Amy, I'm just going to have you do that as we, same thing as we did on the back as we go up that, and so you can really control the movement. I'm going to just make sure that I'm not in her way so she can actually do the movement.
Have you ever had anybody that complains of, like, if they run, it'll feel like electrical shock, pins and needles in their ankles?
Yes.
What is that?
It can be a few things. I would check into the glute medius.
I get it all. If I go to run, sometimes I feel like I'll just fall on my face because it feels like
Does it get numb too, or?
It doesn't get numb. It's just like electrical shock in there, like you could just drop to the ground.
How's that pressure, Amy? Yeah, that could be something that maybe we would look at today if you'd like.
Oh. Just since we're working on that, like ankle, feet, and all that, wondered if it was something.
How's that in there? So I asked because I got to a place that felt different. The tissue just felt different. And I slowed down a little. And I'm going to take the stroke all the way up to the head of the fibula. Any questions on that differentiation stroke? No? Okay. So we're also going to, and let me know if that's comfortable on your knee. Is it, because it's going to straighten it a little bit. Does that feel okay? Mm-hmm. Okay. I lifted her up, and you don't have to. I'm going to have her dorsiflex again, or plantar flex and dorsiflex. And I'm going to go over her retinaculum. Sometimes I still put the pillow under, just so that she can, if she needs to, she can really come. Do you notice how, since your heel's off the table, you can really come down more? But I want to make sure that her knee doesn't feel locked, because now she's supported. And if she did feel locked, I would just take another little pillow or a towel and put it right here. So this way, because the table's not interacting now, she can have a little bit more range of motion in her foot. So now what I'm going to do, or what we are going to do, is I'm going to come through the retinaculum. And this you can actually start pretty high on the foot and come through the whole area while she does the movement, and it can really open up this space. For some people, they like to start where the client is stationary, and you can start like this. I don't find that I really have to. I'm not really putting that much pressure on her, where I'm going to be pushing her foot down. I just kind of let her do the movement, and I'm really just kind of sunk in pretty lightly, and yet it's still, I think, effective. My front leg is in the table, so I'm anchored in. And again, Amy, you just, however you would like to do the movement, what feels right for you. And I'm just coming right through that retinaculum. You can also do some really nice spreading through here. So I can start right at the ankle, kind of like when we did knees. Have we done knees in here? Yeah, we did that. Where they lift into you. But you're not gonna lift, but it's the same movement. I'm just gonna come down with my finger pads and go out and around like this. And so you don't have to do any movement. You can try it to see how it feels. It's not necessary. No, just with dorsiflexion and plantar flexion. I always encourage my clients to play. Like, it's okay to just see what it feels like. It's your body. If you want to move it, go right ahead. Maybe I will learn something. Like, oh, really? So when you do that movement, this happens? That's cool. Maybe I'll ask other clients to do that. So I'm just using my finger pads to come around retinaculum. Again, you can use your thumbs to come into this area. A lot like the wrist, you can do some really nice specific work in the area and move in different directions with it. And usually with this, I tend to take over the movement just in terms of moving them from side to side. You can get right into the, so if you can lift your toes up for me and bring your foot in this way towards you. You can see tib anterior right here, this attachment. So, and you can relax. You can come right in there if you like and work right into the tendon. So there's a lot of work that you can do in the ankle, around the foot. Jen had mentioned the stirrup, how tib anterior comes this way, and fibularis comes this way, and hook in like this to make the stirrup. So you can come in and do some really nice spreading through those attachments. And again, I'm using my thumbs. This is basically reflex to me. But this would be a spreading technique and connective. The foot is a great place to really come in and work the attachments. You can do some lengthening down the foot. So any questions? The knee, the lifting into the knee. So we haven't done that yet. No. Oh, okay. I was like, didn't we? I was thinking we did it in another class. Okay, so I get to do that. Sweet. It's one of my favorite moves. I'm like, didn't you guys do the knee thing? Oh, so this is the knee thing that I was referring to that I thought we did when we did quads for some reason. Nobody wanted to admit that they didn't remember something I already taught.
I thought it was the differentiating in the quads. I figured that's what you must have meant.
Yeah. No, this is yummy. So we're gonna work on the knee. Thank you, Jen. I don't know why I thought we did it already. And so it's kind of like this prayer position, and you have your fingertips, and I'm gonna come down her leg like this, and as I do that, Amy, you're just gonna lift your knee up towards the ceiling. And it doesn't have to be big, you don't have to do this. Just, it can be real subtle. You don't even have to come all the way up the table. It can just be like very lightly. And so I'm gonna do that in 3 places. I'm gonna do it just above the patella and the quadriceps tendon, starting on top of it and coming down. I'm going to do it just lateral of the patella on both sides to come through the attachments here, And then I'm going to go just under the patella and the patellar ligament and come through this way. And each time she's going to lift. And it doesn't have to be one slow, it can be one slow lift, or it can be multiple little lifts, whatever you want. So, to create movement for me to come down. So I'm not doing this. I'm just going to let my finger pad sink in. And as she lifts her knee, so I could just sit here with her, but as she starts to lift her knee, it's going to propel my hands to move down. How's this pressure, Amy?
You could use a little more.
So I just moved my body closer to the table to give her more pressure. And you'll be able to feel your client engage. I don't know, even if you guys can tell or not tell, but I can feel her engaging when she lifts. And really just depending on how you're hooked into the tissue and how much room you may have, you can come down into your hands, or you can stop the stroke as is. I'm going to let my hands come into the stroke. So now most of my pressure is more in the heel of my hands. Is that still feeling comfortable for you?
Mm-hmm. It feels almost like a workout.
Yeah.
Like, what the hell have I gotten myself into?
Fun!
I love it, I love it.
Yeah.
Wow. I like that.
What did you notice with that you liked so much?
Right before you said the thought went through my mind like, oh, I can feel my muscles engaging, and then you said, I can feel she engaged. I'm like, yeah, definitely. It was. I like it. It really did feel like a kind of a workout.
To actually move your leg, or to have the contact?
To be moving my leg against your contact. Like it was, yeah, it was really cool. And I felt like maybe, like, I didn't seem like I felt like I was moving a lot, but I was like, I
didn't see as much. Did you guys notice the movement? How little it was? Yeah.
Was it just really little?
Yeah, and it's
like
totally effective. So it can be something really subtle. Less is more. So again, Amy, just as much as you'd like to, coming through. And if it feels like that workout feeling is uncomfortable, you can lessen it. Or if it feels good, you can keep it on. Now with this one, I'm actually more in my thenar eminence on my thumbs. That fatty pad on your thumbs. There's not as much tissue here, so I'm not in my heel of hands. So most of the attachment sites. There's a lot of nice stuff in the knee that you can come in and do really specific little lengthening strokes and really specific spreading strokes. It's a great area, and I think often it gets overlooked because people are like, oh, the knee. I don't know what to do with that. But there's so much here, so much. And let me know about these bruises. I think I'll be clearing both of them. So, and again, just slowly coming up.
If somebody's had an injury there with their ligaments, strained or pulled or torn the ligament.
I would still do this work with them. Unless they're in an acute phase.
Right.
Unless they're all swollen and stuff, then I put some ice on that while I work something else.
You're not in danger of pulling it the wrong way.
Nope. And I actually encourage people who have had knee surgeries or any kind of knee stuff to get specific work done in their knee because there's usually a lot of scar tissue. And as long as it's not painful to them in any way, just bringing blood flow to the area, which is going to be good. I have knee issues on both mine, and I love getting my knees worked on. So, and how was that for you?
I liked that. I liked when the lateral, when you got around, I guess, to right around the head of the fibula. That felt good.
Mm-hmm.
Spot.
Nice. So, any questions about low leg? So there's a lot more movement involved because it's a very mobile. We really like to use the knee and foot to encourage when we do our differentiation. So if you have questions about that when we're on the table, feel free to ask. All right. So thank you very much, Amy. And if we could let ourselves disperse our attention elsewhere and have her get off. It's not quite over yet. So Amy, again, just taking some time to notice how your feet meet the floor in this moment. And letting yourself really soak up just how you feel standing now and whatever it is that you may catch your attention. Really feeling how your feet meet the floor and coming into your ankles and knees and just letting yourself feel how you are. See if there's one side that feels any different than the other. And bringing that awareness up into your pelvis.
I always think it's people. I always find it so funny when people are like, "Oh, it feels so light."
Uh-huh.
Like, kind of light, kind of big, but I swear to God, I feel like this is like floating.
Uh-huh.
I really do. Go figure. Yeah, the imbalance or the difference. I would rather say the difference between the legs is remarkable.
Okay. So this one feels lighter?
It feels a lot lighter. It feels a lot easier to move.
Mm-hmm.
Whereas this one's still like, oh.
This one's still talking to you?
Yeah. Yeah, it feels a lot different. I notice also too though that I feel like I'm noticing some stuff in my back now that I did not notice before.
Like some soreness happening? Or just a new awareness in your back?
Yeah, mostly just a new awareness.
Okay.
I wouldn't say soreness, but yeah, just awareness.
Mm-hmm.
So
maybe standing in a new way kind of brought you more into your back this time?
Well, I noticed when I did the knee lifting thing, I felt, and I noticed in my hips, my pelvis, the difference there, and in my shoulder blades also the difference there. Just that little movement. So maybe that brought that up.
And how are you feeling in your pelvis?
I still feel that.
Anterior tilt.
Yeah, I feel like I try not to give into it. You know, I feel the desire, I feel that habit there. But yeah, it's still, I think I still have to put forth the same effort to correct it at this point.
Noticing that you are moving a lot more though. So there's some energy going on in there. Cool. Nice. Thank you very much. So we're going to be doing low legs, and if you have questions, please come around. Jen has written it all up on the board for you.